afternoon, everybody, and welcome. I'm so excited that you're joining us. My name is Jen Elder. I'm the director of the Homeless and Housing Resource Center, and we have a great webinar for everybody today on effective behavioral health crisis response. This is a really timely topic, and we have a fantastic panel assembled to give you their best practices and lessons learned today. To get started, we'll start with a quick disclaimer. We are funded by the Substance Abuse and Mental Health Services Administration, but the views expressed today don't necessarily represent those of SAMHSA or the U.S. Department of Health and Human Services. Next slide. So I'll do just a few housekeeping slides and then we'll dive straight into the content. We do have American Sign Language interpretation today. We are thankful to our interpreters, Paige and Kip, for joining us. We also have a live captioner providing transcription. If you're having any technical difficulties during the webinar, please, we encourage you to reach out to us via our email, or you can send us a note in the Q&A. Next slide. So we are joined by a large group today so that you know all your lines will be muted, and because of the size of the group, the chat feature is also disabled. That said, we really want to hear from you. We want to hear your questions, your reactions, your reacting to the speaker and sharing with them. And you can do that using the Q&A feature. So just because we don't have a chat, keep those questions coming to us. If you'd like to go ahead and look at the slides to follow along with the presentation, those are available now at our website, and we'll put the direct link into the chat box as well so that you can grab those. We'll have a recording available in about 1 week on the HHRC website. And at the end of the presentation, we'll provide a link for a very short evaluation. We welcome your feedback, and we'll also provide you with a certificate of participation at the end of that evaluation. So we'll have that closer to the end of the session today. Next slide. So today's presenters, like I mentioned, we have a fantastic group. Jordan Gully is a senior associate at TAC, and she'll be walking us through the background and the presentation and facilitating our expert panel. Today, our expert panel is made up of Stanley, Emily, Eric, and Shireen, and they'll get to introduce themselves much more fully later in the session. Their full bios are available now if you'd like to read them on the HHRC website event page. And so with that, I believe I am turning it over to Jordan to get us started. Thanks so much.
Thanks so much, Jen. I'm really excited to be here today. And as Jen mentioned, we have a great panel with really rich expertise that will be talking about some of the more practical strategies. And I am just here to be your tour guide in this process. So on the screen, you'll see the agenda. I won't really go through all of it, but just wanted to start with saying that we're going to lay a little bit of groundwork to discuss factors that contribute to a potential cycle of crisis. And there's so much happening right now in the behavioral health crisis world. Systems are revamping and changing. And so we'll spend a little bit of time just talking about system planning and federal investments, just to level set kind of some of our conversation. And then the majority of our portion will really be engaging with the panelists around strategies for more effective crisis response for individuals experiencing homelessness. At the end of our slides, you'll find some resources, and just a note that HHRC, the Homeless and Housing Resource Center, will be releasing a brief that coincides with this topic that digs a little bit deeper on some of the strategies that we'll be discussing today. But I think before we get started, I think it would be helpful just to get a little bit more information about who's in the room. So next slide. We're going to pull up a quick poll and just want to get a little bit more about who's joining us today. So if you could tell us a little bit more about yourself and which just best describes your professional or personal area of focus. And we also want to get just a little bit more information about how familiar you are with 988. So the poll has popped up, and we realize that for the professional and personal area of focus, they're not mutually exclusive. So please check all that apply for you. And I will give it about 15 to 30 seconds, and then we'll talk through some of the results. Okay, perfect. So it looks like we have about 50% individuals working with individuals experiencing homelessness or in the housing system. We have about 15% of people who are qualified mental health professionals, 14% people working in the behavioral health crisis field, about 11% of a person with lived expertise or a person in recovery. Some care coordinators and case managers, about 37%, 8% identify peer support staff, and about 15% are program managers, 9% program directors. So, and then familiarity with 988. It looks like we have the majority falling into, I've heard of 988 and have a general understanding of the services. And if you want to go to the next slide, I think that the poll question's on the next slide. Yeah, so we have a fair amount falling into, I've heard of 988 and have a general understanding of it. And about 19% have heard the number but don't know a lot about it. And about 33% of people in attendance today have not heard of 988. So we, in light of that, we want to make sure that we're all working from the same understanding. So we're going to spend a little bit of time just talking about some of those aspects of the crisis system and what's been going on. So next slide. So just a quick overview of what our objectives are today. We really want to talk about the detrimental impacts that can happen when there's an ineffective crisis response system for individuals experiencing homelessness, for Black, Indigenous people of color, for other vulnerable communities, really kind of laying the groundwork of why it's so important to have effective crisis response and effective upstream behavioral health services. So services that meet people where they are and get them connected to resources. And as the poll indicated, we're going to spend a little bit of time talking about 988 just to give people an understanding of what 988 is and also necessary components of an effective behavioral health crisis response system. And then we'll spend the majority of the portion talking about opportunities and strategies for cross-sector collaboration between behavioral health providers, between homeless and housing service providers, and just effective strategies across the board for individuals to provide more person-centered and effective response to individuals that might be experiencing a behavioral health concern. So next slide. So first, I just kind of wanted to take some time to level set and talk about the need, as well as just define some shared language. So we're all working off of the same operating book. So for the purposes of today's session, we're defining behavioral health crisis as an emergency that a behavioral health crisis is an emergency that is created or perpetuated by emotional distress, a mental health condition, or substance use. Throughout this, we may use crisis, behavioral health crisis, or behavioral health emergency interchangeably, and it really will be referring to the same thing. Behavioral health crisis should be defined by the individuals who are experiencing the behavioral health crisis. And so for that reason, there are many ways that situations may manifest themselves. And I think at this point, there's a universal understanding that COVID impacted everyone's mental health, and the behavioral health symptoms rose across the nation, while simultaneously there was a shortage in behavioral health workforce that limited and created additional barriers to access to services. And so for this reason, I've really pulled statistics from the last 3 years. So in 2020, the United States had a death by suicide 1 every 11 minutes. And suicide is a leading cause of death in individuals aged 10 to 34. And suicide attempts and suicide completion rates are high among LGBTQA+ individuals, particularly youth. And during that similar time frame, the United States saw an increase in individuals dying from drug overdose. We had about 100,000 individuals who died from 2020 to 2021. And as I mentioned, there was an increase across the board in rates of depression and anxiety. And it's estimated that in any given year, 1 in 20 individuals in the United States will experience a serious mental illness. And so I think one of the points that's particularly jarring and important in this slide is that for a variety of reasons, the estimate is that only 22% of individuals with behavioral health conditions get the help and support that they need. And if people aren't accessing the services that they need, that creates potential for crisis. And so next slide, we're going to spend a little bit of time talking about the potential cycle of crisis. And I say potential because it is not the case for everyone, but this cycle can happen when individuals lack access to culturally responsive services that meet people where they are. And this lack of access to, and also with a lack of access to positive social determinants of health. For a lot of you, social determinants of health may be a known entity and you have an understanding of it, but just to define it, social determinants of health are conditions in the environment where people are born, where they grow up, where they live, and where they work or go to school that impact their overall health. And these are factors that are outside of the, quote, traditional medical health considerations, and they impact overall health. And these aspects are things like access to housing and income, food security, transportation, geography, social support. So all of the holistic things that support the health of an individual. We know that there are inequities in access to social determinants of health, and these inequities are often rooted in racial and systemic barriers that are faced by marginalized populations. So BIPOC, LGBTQA, individuals living in rural communities who have systemic barriers to access. And we understand that these identities are not mutually exclusive and that there's a great overlap and potential for compounding oppression that can be drivers for individuals experiencing homelessness and drivers for behavioral health crisis. And so for the purposes of today, we're going to spend some time talking about kind of the impact of this cycle of crisis, particularly as it relates to individuals that might have behavioral health concerns that are experiencing homelessness or have psychological or physical stressors that of homelessness that can perpetuate or exacerbate symptoms of crisis. And so this cycle, there's a potential to intervene at all the stages of this cycle, but often when it reaches the point of crisis, an ineffective response to that crisis can also accelerate this cycle and create unintended negative consequences. So an example of that may be in a community where the default response to a behavioral health crisis is 911 or law enforcement. Often law enforcement may not be equipped to respond to behavioral health concerns. The presence of law enforcement itself may escalate a situation. An individual may have had previous encounters with law enforcement that are negative, and the situation escalates. And so the whole process can create negative and avoidable outcomes that can result in re-traumatization, unnecessary hospitalization, arrest, incarceration, and unfortunately, in some cases, even death. And this ineffective response can also result in lack of access and additional barriers to social determinants of health. So what does that look like? It can be individuals not being able to access stable housing because through this inappropriate interaction with law enforcement, because they were having a behavioral health crisis, maybe they were arrested and now they have a criminal record, or they're incarcerated or institutionalized in a hospital and have a loss of income or a loss of where they were staying and end up homeless because they've been in the hospital for a long time. So we're going to discuss some of the potential impacts a bit more and strategies to intervene in this crisis. So next slide. And so what does that practically look like if somebody has this cycle of crisis that is perpetuated by an inappropriate response to behavioral health crisis. So we won't spend a lot of time on this because I know there's a lot of providers that work directly and can see some of the results of an ineffective crisis response. So what does that look like practically? Often individuals with complex behavioral health concerns maybe don't have access to those positive social determinants of health. They may have a history of trauma and traumatic events or abuse. They may be lack of adequate connection to the upstream behavioral health services that can perpetuate crisis. And when this happens, an individual is more likely to have interactions with law enforcement. When they have a behavioral health crisis, maybe they're unsheltered and somebody else calls law enforcement on them. And so what can tend to happen is somebody can cycle and have frequent contact between the shelter system, the ED, inpatient units, the criminal justice system, and there's a lack of continuity of services. And all of the different components I just talked about can cause this perpetuation of a cycle of crisis and can exacerbate behavioral health conditions. And so I'm going to turn it over, next slide, I'm going to turn it over to Stanley, who's going to take the lead on the next part of our presentation.
Hi, everyone. My name is Stanley Eugene. I'm currently homeless, as all you guys know, trying to get away from being homeless, but it's a process that sometimes is not easy, but I'm having faith that working with community connections will help me get to the location that I'm trying to get away from this homeless situation, because it gets depressing at times and helps you get stagnant and impatient with everything in general. I became homeless about 2.5 years ago due to my health conditions. I suffer from epilepsy and sleep apnea, forced me to not be able to work and not to be able to drive. Therefore, I'm in the current process of trying to obtain Social Security, but I've been denied several times, and that's also made life even more difficult. Community care is helping me with, assisting me with all these things to get where I'm trying to go. It's going to be a process, but we're getting there step by step. At times, I can be, down and, look at things in a negative way, but I guess life is sometimes rough and it's not easy. So you're gonna have to go through the ups and the downs and the ins and outs. Working with community connections and Felicia Majors in particular, she assists me and helps me understand that it's a process. It's not supposed to be easy, but it's a process that if you got faith and you're consistent with the things that I need to do upon myself, that it'll be an easier step to get to where I'm trying to go, to obtain an apartment so I can possibly get my health even better, to get my health back together and better so I can get in some type of work environment and bring my life back to the status I'm looking for. You guys are open to ask me any questions if you would like.
Sorry, I was on mute. Stanley, thank you so much for kind of taking the time to talk a little bit about your experience and what's going on. And I think you spoke to some of those access to health services and having you identify Felicia as having somebody that can help you access those resources. So I think it's incredibly impactful and helpful because it reminds us that some of these strategies that we're going to talk about and integration and why it's so important to help disrupt some of that cycle that happens.
Exactly. Thank you. I appreciate that.
I really appreciate your time. And Stanley is going to join our panelists in just a moment after we go over our overview of 988 and the behavioral health crisis system. So next slide. So as some of the answers to the poll indicated, you all are aware that when an individual calls or texts or chats to access 988 services, they're connected to a trained crisis counselor who can listen, support, de-escalate the crisis, and ideally provide linkages to ongoing supports that can address some of the social determinants of health that we've been talking about. Though 988 rolled out in July of 2022, it was not necessarily new. It was built on the foundation of the existing National Suicide Life Prevention Lifeline infrastructure. And it was a shift to a 3-digit number to do a multitude of things, one of which is to provide an easy to remember number that people can access when they may be experiencing severe emotional distress or having suicidal ideation or having a behavioral health crisis. It can serve to reduce the stigma and makes it easier to have parity with physical health and public health safety, because it creates a foundation for centralized access to health-led responses to behavioral health crisis. 988 is distinct and separate from the emergency and medical and public safety response that's associated with 911. And as we talked about earlier, law enforcement response can be traumatic. And so 988 is offering an alternative to 911 where people can access behavioral health-led services and talk to someone who's trained and understands and can engage in effective behavioral health strategies and de-escalation in order to listen and assess and figure out what's going on with the individual and work with them to identify what resources might be beneficial to the individual. And so, next slide. How does 988 work? So 988 is a national number that if anyone dials, texts, or calls that number, they are routed through a centralized access point. And they're routed to one of over 210 local crisis call centers within the network. And these call centers are based on area code. So the thought is if you call, they'll route based on your area code to a local resource center. And the thought is to try to get you connected to local resources as appropriate. And so there's also a national backup line to ensure that if a local call center doesn't have capacity, or if somebody's not able to answer, that someone in that national line will answer and offer that support. And so 988, the number went live in July, and just a little glimpse of what happened is the volume increased in that first week of July of 2022. The volume of calls that came in increased by 45% of people reaching out, trying to get support. And in November of this past year alone, there were over 250,000 calls with an average response rate of 36 seconds. So individuals could call and within 36 seconds access a trained crisis counselor who would be there to listen and support and really facilitate access to some of those resources that we talked about, connecting people to those upstream supports. And so I think the sheer number, the 45% increase and the just over 250,000 calls in a month is a testament to the fact that an easy to remember and easily accessible number is helpful in getting people to a place. People want access to services, and now that they have an easy to remember and centralized access point, people are calling and they're reaching out for those services. So next slide. So when thinking about kind of the cycle of crisis that potentially can happen, the potential impact of 988 is really important. It's an important step in reimagining crisis response and creating a foundation for a health-first centralized access to crisis services. So nationally, we know that a majority of calls can be resolved without the need for an in-person response. Individuals reaching out maybe just need to talk to someone and engage with a trained counselor. And so those calls can be resolved over the phone. But in order to provide kind of a truly responsive crisis system, 988 needs to be integrated with and coordinated into a broader crisis system. And I spoke to earlier, there's a lot of investment in the behavioral health system right now, and there were significant federal investments into supporting states really building out a comprehensive continuum and array of services. And those services are catered to meet the level of need of the individual, to really be able to meet the need of the person. If they just need someone to talk to, they have 24 access to somebody to talk to, but they may need someone to respond. They may need somebody to come and engage them where they are and really physically meet them where they are. And in order for 988 to facilitate access to those other services, there needs to be integration into a broader a broader crisis array of services. And so what do I mean when I say a broader array of crisis services? Next slide. So SAMHSA defined 3 core elements to a crisis continuum: that there's someone to call, someone to go, and somewhere to go. And ideally, this will look differently in every community. It should be based on the needs of the community, the needs of the individual. But services should be as streamlined as possible, so that if somebody experiencing a crisis knows they can call 988, they can get access to a trained crisis counselor. But if they need that additional level of support, then 988 should be integrated into the system to be able to send someone to them, that someone who may be a mobile crisis unit. So a mobile crisis team is often a clinician paired with a peer support specialist, a clinician paired with a mental health specialist, someone who's trained in behavioral health services and de-escalation, and someone that can go and meet the individual where they are and have a behavioral health and a health-led response to be able to meet the individual and assess the needs and really figure out what services they would be receptive to and what services are available in the area. As I mentioned previously, 988 implementation looks different in different communities right now. In some communities, 988 is directly dispatching mobile crisis teams. And maybe 988 also has access to registry of beds that know where an individual can go if they're in crisis, if they can go to a crisis stabilization unit. And a crisis stabilization unit is somewhere in the community that provides short-term crisis stabilization. And really the goal of crisis stabilization is to redirect people from staying in a hospital or sitting in an ER or not getting effectively connected to the services that they need in the community to stay in the community and stabilize the crisis. So in some communities, those systems are very integrated. In other communities, 988 is coordinating closely with the mobile crisis team. They may not be dispatching, but they may be calling them and doing a warm-handed referral. In other communities, the systems are still actively planning. Maybe they don't have a current array of crisis services, but they're working across behavioral health providers, public safety entities, working with individuals with lived experience, loss survivors, providers in the community to really figure out what the need is and build out that crisis continuum. So I feel like it's important to place emphasis on the fact that in many places, the complexities of building out a robust crisis system will take years. But that being said, I think there are strategies that providers, regardless of where their community is and planning, regardless of kind of how integrated those services are, there are things that providers can do in real time to kind of disrupt the cycle and really support individuals who are experiencing homelessness that also may be having a behavioral health crisis. And so I'm going to turn to our subject matter expert panel to start a discussion of these strategies. So next slide. Awesome. So, I think you can probably take the slides down, and there we go. So I'm going to have our panelists introduce themselves, and I'm going to start with Emily. And if you can just talk a little bit, introduce yourself and talk a little bit about your experience with the behavioral health system.
Hi, everybody. My name is Emily Miller. My pronouns are she, her, and I work as the Senior Manager for Clinical Entry Services at DESC in Seattle. I am by training, I am a licensed clinical social worker. I've been working in this field for about 10 years and for about 3.5 years at DESC. DESC is a nonprofit here in Seattle that serves adults experiencing homelessness in the community. Going back to the recent slide here about the continuum, DESC is a pretty large organization, and we do have programs intervening at every step of that sort of crisis continuum. But one of the programs I oversee is a little bit unique, and I'll be answering the panel questions through this lens. So one of the programs I oversee is the Crisis Respite Program. And the CRP really falls into that somewhere to go part of the continuum. CRP specifically serves people being discharged from inpatient psychiatric or substance use disorder treatment. So that individual who is experiencing homelessness and then also experiencing a behavioral health crisis. For those folks who do end up being hospitalized or in some cases incarcerated because of their behavioral health condition, we notice this cycle of people being hospitalized and then being discharged to the street, decompensating, and then ending up right back in the hospital days or weeks later. And so CRP is really intended to catch that group of people when they're coming out of the hospital to provide a more intensive, supportive, transitional environment. So we are an enhanced shelter. We are staffed 24/7 with clinical case managers. We provide intensive case management and medication monitoring to the people staying in our program. It's a voluntary program. So it's really focused on, as people are coming out of the hospital, making sure that in the time that they're with us in our program, generally about 45 days, anywhere from 1 to 3 months, we are really helping them get stabilized on their medications if that's something that they are interested in doing, and connecting them to the outpatient behavioral health supports that they need to be supported successfully long-term in the community. So connecting folks to outpatient mental health or substance use treatment, primary care doctors, helping folks replace their IDs, helping them apply for housing resources, whatever it is that they need to be supported and successful in the community long-term and break that cycle of rehospitalization and utilization of the crisis response system.
Thank you so much, Emily. Shireen, do you want to introduce yourself and your role?
Sure. Thank you, Emily, and thank you, Jordan. Hi, everybody. It's great to see you. My name is Shireen Carrico. My pronouns are she and her. I live in Charlotte, North Carolina. I am a psychiatric survivor. I came into mental health services when I was 13. And as a matter of fact, had my last suicide attempt directly in response to a threat of an involuntary commitment by my behavioral health professional. So I'm going to share with you throughout the panel my experience from that vantage point of my lived experience. I also am the CEO of Promise Resource Network, which is a completely peer-staffed and operated organization in North Carolina. We have a team right now of a little over 100, about 120 folks, and we serve people that are uninsured, underinsured, who have that complex, vulnerable combination of being labeled with mental health issues, substance use issues, houselessness, and incarceration, right? So all of the folks that probably many of you are supporting right now, for whom services were not designed by, with, or for. So in our community, we are a safety net organization that supports all of those folks through the vantage of lived experience. So our team are people that are psychiatric survivors, suicide attempt survivors like myself, overdose survivors, people that have been incarcerated. Probably about, at this point, 80% of our staff have felony backgrounds, up to and including facing life plus 100-year sentences. So I'm not talking about having been in jail overnight. I'm talking about people with pretty significant, extensive experience in the carceral system. Probably at this point, about 35 to 40% of our team have experienced long-term houselessness in our community as well. And all of our team members are in recovery from mental health, substance use, or a combination of both. The programs that we operate, there's some fundamental things that I want to share as a peer-run organization. Number one is that we are a zero force and zero coercion agency. And when I say zero, I mean absolutely zero. We do not use force. We do not use coercion. We do not use involuntary treatment, involuntary confinement, and we do not use police intervention. We are part of training our police officers. I see a lot of questions in the Q&A about police involvement. We've been doing police training for many, many years in our city. And we work with people that have experienced harm by services, systems, and at the hands of police. And so we want to be very intentional about not re-traumatizing people in the name of treatment. Second thing about our organization is we work with people that have been kicked out or have walked away from services. So all the folks that the shelter won't serve, or they can't show up at a homeless resource center, or behavioral health providers will not work with, or a housing system has said they will never be housed here in our city, those are the folks that we typically work with. So I'm going to share as a panelist some of our experiences around that. Last thing I'll share before I turn it back over is that we operate several crisis prevention, diversion, and alternative responses. Open access, no barrier, or low barrier responses, including a couple of 24-hour-a-day, 7-day-a-week crisis alternatives. One is a 24-hour-a-day, 7-day-a-week phone peer warm line. I saw somebody reference it in the chat, which I was really happy to see. It is a very high volume call number that people can call 24 hours a day, 7 days a week, as frequently as needed to talk to a peer supporter to work through distress and a variety of life stressor issues. We also operate a peer-run respite, different from what Emily was talking about. Our peer-run respite is in a home, in a neighborhood. It is completely staffed by people that have been directly impacted by suicide attempts, involuntary treatment, crisis response, and it creates an opportunity for people to voluntarily engage in crisis supports and not have to default to carceral care, involuntary treatment, or police intervention. So again, as we go along, I would be happy to share more about our experience, wisdom, things that we've done well, things that we've done very poorly. I will be very open about all of that. Thank you, Jordan. Thank you, Emily.
Thank you so much, Shireen. I'm very excited to dig into that. I want to make sure we introduce our other panelists, and then we will really get into the meat and potatoes. Eric, did you want to introduce yourself?
Good afternoon. My name is Eric Scott. I'm a peer specialist for the Department of Behavioral Health, the Community Response Team, and I have lived experience with over 26 years of incarceration, substance use, alcohol abuse, and homelessness. I would say this is like the best job that I ever had, not money-wise and nothing, but it's about me helping people, like countless people help me, or even in the past try to help me. So I always approach an individual or a situation like it's me, because I always look at it that I'm not better than nobody else, because I do have lived experience. Just because I'm in a different situation, that don't mean I'm better or I got this. And that's how I look at a situation. I've been with the Community Response Team now, maybe about 3 years. Been with DBH as a contractor about 6 years. Jordan gave my first job, trusted me or whatever. But I think being a peer, when you dealing with people with homelessness or even mental health crisis, because a lot of it, that's what substance abuse come from, because they're trying to mask something. They're dealing with depression or whatever, and I deal with depression, and I'm connected with an agency, mental health agency. So yeah, that's all I have right now. Thank you.
I really appreciate it, Eric. And I think we're already pulling up themes around, self-medication and trauma and how to treat trauma and systems that maybe are ineffectively responding to trauma. So I definitely want to dig in here. Stanley, I know that you have already spoken a little bit, but just wanted to bring you into the panel discussion as well.
Okay, no problem, no problem.
All right. And so earlier throughout the slide, we were talking about discussing the potential for cycle of crisis that's perpetuated often through racial and systemic barriers and inequity in access to social determinants of health. And Shireen, you talked about systems that are not necessarily built by the individuals receiving the services. So I'm going to start with you, but can you talk a little bit about how individuals working within these systems that kind of are created in larger systems, how they can work to fight some of these systems of oppression and really challenge that status quo?
Well, sure. So part of the work that we do is on the policy side and the social justice and social injustice side. So not only do we work with people, but we support people to organize and mobilize and strategize around practices and policies that negatively impact their lives. And what we find is there's a wisdom that goes along with shared experience around solutions that other people can't even imagine, right? So when you're a person that experiences it, the solutions that we're looking for from our community with our community oftentimes look very different than what systems have provided. And so we have got to take a look at what's going on around the country, around our own community and our own state, and identify those key points that we want to be able to organize around. So I'll give you a couple of really concrete examples. If you live in California, you know about the Care Court policies and mandate that is coming down. And if you live in New York, you know about what's going on around policy from the governor to use involuntary commitment for people that are experiencing houselessness. When we look at what's happening around the country, a lot of these policies are predominantly targeting people at that intersection of poverty and houselessness, who have perceived mental health or substance use issues, who also have perceived lack of compliance or unwillingness to voluntarily engage in services. We look at that and we recognize that we already have harmful approaches in place, right? There's a reason why we have the highest emergency department boarding rates in our country, the highest suicide rates, the highest overdose rates. We did a scan in our own state, gathered data, and realized that over a 10-year period, we are at a 100% increase in the use of involuntary commitment in our state alone. When I couple our data with looking at these policies, we know that there are several things that are in play here. There's racial inequity. There's lack of access on the front end to things that feel helpful and healing and supportive. Many services are not relationship based. So they're not based on engagement and connection. They're not reaffirming. They're not healing. They're not trauma informed. And people walk away from these services. Or if you have been police involved or involuntarily committed, there's an experience of trauma in the name of treatment that occurs that really does reduce the risk of people voluntarily showing up for services that we feel are harmful. And so as you're thinking about your own community, I really want you to think about more of the national scale, how that's affecting your state, how that affects your local community, and ways that you can come together and look at what's happening, some of the best practices, some of the innovations, and be led by your own community to push the needle, if you will, around the narrative around mental health and homelessness. The truth is, and you all know this, the narrative right now is that people that are experiencing homelessness are dangerous, and people with mental health issues are dangerous. We have got to do a lot of work and education to change that narrative and create space for people to influence what's happening around the country in their community.
100%. And Shireen, I really appreciate your perspective. I want to see if any other panelists have additional thoughts on it.
The only thing I'll add here to this conversation is that the system is built to maintain itself, right? We talk a lot about how, you know, it's a broken system. In reality, the system is entrenched in white supremacy, and it is functioning the way that it was intended. And if you are not actively working to deconstruct that system, you're complicit in maintaining it. So it's about knowing your biases, knowing where your blind spots are, and about maintaining your engagement in redesigning and reworking the system.
Thank you, Emily. I think this is a great conversation around, you talked about knowing your biases, so can you talk a little bit about how providers and systems can advance culturally responsive crisis services that really are meeting individuals where they are within this system?
Yeah, I think the first thing that's coming to mind here is that the two sort of foundational pillars of everything we do at BESC are harm reduction and housing first. They go hand in hand, and if you're not familiar with those concepts, the snapshot, basically the summary is you can't help someone who's not there, right? And so everything we do at DESC is through this lens of how can we keep people engaged? How can we keep people here and safe so that we can get them to where they want to go? We look at all of our programming through a lens of low barrier or no barrier access to services. So it's about, doing everything we can to take down those walls that are getting in the way of people accessing the services that they need, that they identify that they are missing from their life, that they need support around.
I think looking at comprehensive and holistic access to resources. Eric, I saw you came off mute. Go ahead.
I could say that sometimes consumers have to, it's best to advocate for themselves. But I would say no. I think they need someone as a peer or a good case manager that will advocate for themselves. Sometimes you don't have to tell a consumer what to do. Just sometimes listen to this person and see what service he wants. Because sometimes you listen to this person and you just listen without really saying nothing, really listen to what he's saying and help him around that. You'll get more out this consumer instead of trying to push this and that on this consumer, because they're going to end up shutting down. And I know for the prison system, I'll never forget in 2012 when I got diagnosed, man, they was experimenting on me. I came home as a zombie. I was just blanked out. I could, I'm just staring. A lot of people you see now think that a lot of times when people spaced out or whatever, they think that they high off drugs. But a lot of times they ain't. It's the medication. Sometimes, I'm not saying the agencies, but I'm just saying the experience I had as far as incarceration that they were experiencing with me, where I didn't know myself. My family didn't even know me because of the way that I was. So a lot of times just listen to the consumer, and hopefully you be that good caseworker, peer, or whatever, that you advocate on his behalf because you listen to what he's really trying to do. Because if you listen, he really going to work hard so you could work hard for him or her.
I agree with you, Eric. I agree 100% with you, because I take over 14 pills a day, and sometimes I'm just, I'm staring off, and people make the assumption that, you're inebriated, et cetera, and it's not like that. Sometimes you're just in the zone. You feel like a zombie, just feeling like a bird in a cage, and you're just trying to figure things out. So it's best at times, if you feel better when my coordinator listens to me and actually hears out what I got to say before she makes an action. So I agree with you 100%.
Yeah, I would add shared experience cannot be replicated. There is nothing like somebody who understands what it's like to have to figure out where to eat at 2:00 in the morning on a Saturday when everything is shut down. It's not a food pantry. It's not a referral. It is going to the grocery store that discards the freshest meat on a Saturday. And unless you have lived that life, you're not going to truly understand the resources and the survival and what it takes to be able to be on the streets and to be able to survive on the streets, right? And I see so many organizations that work with people experiencing houselessness that nobody that works there has ever experienced homelessness. And it blows my mind, right? Because that's an experience that cannot be replicated. I got a question in the Q&A. How do you, without police intervention, without force, how do you serve people that may be angry or aggressive or violent? I will tell you, in the 20 years we've been operating, so our organization has been around for a long time, we serve thousands of people every month in an open access, no referral, no clinical assessment, no insurance requirement. In all of that time, we've done one involuntary commitment petition. What I find is safety is created by valuing another person, by honoring and uplifting their voice, by not walking in with an agenda and an expected outcome and trying to push your agenda on another person, by understanding the cultural relevancy that's important to them, by truly getting the trauma and the survival that goes along with people showing up every single day and putting yourself out of a position where you're not managing, you're not monitoring, you're not trying to confine, you're not trying to tell anybody to do anything. When we take the power struggle out of the power struggle, there's no there, right? There truly isn't. What you are left with are people on a journey together trying to figure out where to go next. And we're all on the struggle bus, one way or another. Some of us are open about it. Others of us are in denial. We'll work with denial too. That's okay. But the truth is, when we shed ourselves of all of that other stuff, what we are left with is human connection. And there are no cliff notes for it. It doesn't matter what type of program, what type of model, what type of funding, or what degree that you have. It's irrelevant if you can't sit in relationship with somebody that is affirming and respectful. It has to start there. When it starts there, safety issues end up lessening, right? And people have a hard time understanding that, but it is the absolute truth based on our experience.
I agree. Yeah, I agree.
It really starts with this place of acknowledging and recognizing that you are the expert of your experience, right? People engaging in our programs are the experts of their experience. They know what they need, and we have to trust that. And we have to, that has to be driving everything we do, that they know what they need, and they're doing the best that they can with what they've got. Yeah. Thank you, Shireen. That's great.
And I learned too, like a person, they know if you genuine, if you coming from a book standpoint or you coming from lived experience. They know, and they will respect you more by you sharing their story, sharing your story with them. And sometimes you don't even have to share it with them. They just know.
That's right.
And they'll respect you more, and you won't have no problem. A lot of times you won't have no problem with them.
Eric, there is like a knowing, right, that we have when we look at each other, that
Yes.
you have shared experience that words aren't even required. There's an understanding. You don't have to keep sharing your story over and over again.
Mm-hmm.
You don't have to get into the nuances of your experience, but there's an exchange of a knowing, and that exchange just cannot be replicated.
Mm-hmm. I agree.
I feel like this is a great discussion. We're hearing really good themes around active listening, engaging empathetically, working with the individual, and not pathologizing behaviors, not assuming it's related to something, but really looking at that root cause of behavior. And people get their needs met, and if the system isn't working for them, they find ways to get needs met. And so really looking at not pathologizing behaviors, listening to what's going on, really engaging individuals and trying to walk alongside with them. So a question that comes up often, particularly for individuals that maybe are working in an area where there isn't a crisis infrastructure, or maybe systems aren't receptive to building out that crisis infrastructure. And I've seen it in the chat a little bit. I've seen it across working in crisis systems. So I'm curious what advice you might give to a provider that's working in an area that maybe doesn't have that robust array of services.
Build it. You know, I'm a Chicago transplant to New York down in North Carolina. So I had a lot of things going on when I moved to North Carolina, including moving to a southern state. And I moved to a southern state where I was accustomed to human rights being a central theme in the communities and the cultures that I resided in. And when I moved down here, it was, North Carolinians are not going to be surprised. I won't get hate mail because they hear me say this all the time. But when I moved down here, it was like moving about 20 years behind in time relative to behavioral health and houselessness and incarceration and substance use. I would talk about harm reduction and people would look it up. I would talk about peer support and people were Googling it, right? So I walked into a system that did not have an infrastructure in place around prevention, diversion, and alternative response. But we have to show up in our community if it's important to us, which means that we also have to find who our allies are, what the messages are that are important, what the priorities are in our community, where are those pressure points around policy, around practice change, and if nothing else, create it. Many of the things that we created as a peer-run organization did not exist. We are the first peer-run organization in our state. People didn't know what peer support was. And I had this moment where I had to make a decision. I either leave, do something different, or literally leave the state, or I stay and figure out how to bring things into our community that wouldn't otherwise exist, which means that I had to be a strategist. I had to align with the right people. I had to find the right people. I had to do a lot of the education. I had to be connected to my community of people with lived experience. And we had to be guided by what is helpful versus what is harmful to people and not be guided by systems barriers.
I think a lot of this, in order to, Shireen and I have had lots of conversations about flipping the system on its head. I think in order to flip the system on its head, so to speak, all of this ties together in a nice thread of you have to listen, you have to assess, you have to know where the gaps are, you have to advocate. So I think a lot of these themes that are coming up are really how you flip the system on its head. And so I see our chat, our question and answers are very, very lively. So I'm going to pull from some of those. But I think before I go to those, I wanted to get from each of the panelists what 3 actionable takeaways you would give to participants today that may be supporting individuals who are experiencing emotional distress or a crisis. And Stanley, if it's okay, I'm going to start with you.
Well, dealing with emotional stress in this process would be, one would be patient. You have to find some form of patience, some form of peace. So, because like I said, it gets rough, it gets shaky, and you gotta be prepared to just hold that peace, find that corner that you can find that peace from within and figure it out, along with getting the information that's necessary to help you figure it out. Of course, being patient and having someone to rely on as well when you don't know what's going on, when you're not understanding it, having someone to rely on to help you understand it, to sit down and discuss what you don't understand and help them so they can help you understand instead of making assumptions and assuming. You're on mute. I can't hear you.
Sorry about that. Yep, 100%. I agree. Eric, do you have any actionable steps for individuals who are attending today?
I would say, going through a crisis, find you someone that you could trust and talk with. Somebody that's just gonna listen. Sometimes the person only have to agree with you, don't have to say nothing, but just trust somebody that's just gonna listen to you. Sometimes you gotta take constructive criticism. But I would say just voice your opinion. If you were the agency, let them know what you want, without what you looking for from them, and hopefully that they listen to you and they give you what you want. And what earlier, I feel that like different programs or whatever need to build a relationship with the person. Go out there in the community, not just the phone calls or whatever, because the person is not going to respect that. But if they see, even though they're angry or whatever, if they see you keep coming up, like I used to do when I used to do outreach, all right, I see you tomorrow, man. I'll be here tomorrow. And then eventually they keep seeing you. Now you having a good conversation with them. They trust you, whatever, because regardless how much you done cuss me out, you see that I kept on coming. So I feel that like a lot of programs just need to just build that relationship and make it happen. That's it.
I would add that there is a significant paradigm shift that needs to happen within systems and services. We have built an entirely illness-based, pathology-based system. And what I've learned throughout the years in my own personal recovery experience, and then walking alongside people for almost 3 decades now, is that when we plant, seed, and water illness, we grow illness. Our traditional systems are based on this belief of behavior management. The best we can expect is stabilization, functioning, and maintenance. Quality of life, recovery, healing from trauma, thriving is not even in the worldview, let alone baked into the way that we engage people, how our supports and services were designed, or how we remove barriers for people to navigate the hardest moments of their lives. So I tell people, I left the illness business a long time ago. When I started a peer-run organization, I centered myself squarely into the wellness business, which means that we talk wellness, we see wellness, we plant wellness. Hope is part of our tools, right? We see people change their lives and reclaim their identities in the most amazing way when we shift from this perception that people are sick and broken and need to be fixed versus that we've been given everything that we need to heal. And sometimes you just need support and the right tools and a safe place to be able to pick up those tools and use it. And so one of the easiest ways for all of us is to reframe our thinking around illness and pathology to wellness, healing, and recovery. The truth of the matter is the majority of us recover. My first psychiatrist at the age of 13 told me I was always going to be sick. He told me I wouldn't be able to go to college, that I was going to spend the rest of my life in and out of psychiatric hospitals. He was wrong, right? Like, we can be wrong. And when we are wrong and we infuse that illness message and identity onto people, people carry that with us. It seeps into our soul. I lived the life of a mentally ill person for many, many years. And unfortunately, I had to find my way out of that, and I had to walk away from services in order to realize who I fully was and to be able to heal, not only from the trauma that caused me to get into mental health services, but also the trauma that I was inflicted upon me at the hands of service providers in the names of treatment. We have control over how we show up in relationship with people, and we have control over how we treat people. Let's start with viewing people as having unlimited potential to have a full life of wellness, not just stabilization. The second part of that, and I'll be brief about it, is stop focusing on behavior, right? Behavior is communication. That's what it is. People communicate with us through our behavior. We are communicating with you through our behavior right now. And if we saw you, you'd be communicating with us through our behavior. The ownership is on us to understand what people are communicating and supporting them to get their needs met, rather than focusing on maladaptive behavior, decreasing behavior, increasing behavior, shaping behavior, managing behavior, monitoring behavior. Stop, right? Instead of focusing on behavior, let's focus on understanding a person's experience and then supporting them with unconditional regard. Basic things, right?
Emily, did you have anything to contribute?
Sure, yeah. Some actionable takeaways that come to mind for me are reduce and eliminate barriers whenever possible. Regardless of where you work within this system, even the most direct service provider, frontline staff working in this field, you are the steward of resources. You hold privilege and power in this system. And so you have the responsibility and you have the opportunity to not be a gatekeeper for those resources and to eliminate the power differentials wherever you can. And with that, think outside the box, get creative and be flexible, because it's never going to go according to plan. And you need to be adaptable, and you need to shift and pivot and get creative in order to make a difference in this work. A thought that came to me earlier was, in this field, we often say, I wish I had a magic wand. I wish I could wave a magic wand and fix everything. Magic wands don't exist. But the two closest things I've found to a magic wand are coffee and cigarettes. Do what you got to do. It's about, getting creative and being flexible and meeting people where they're at with what they need.
You're speaking to my outreach heart, 100%. Coffee and it really is. It's meeting basic needs. It's meeting what that person needs in the moment. It's a lot of the things that we've talked about here. I'm looking to the chat. It's been blowing up with questions. I'm going to start with, for individuals with lived experience, if say the provider is engaging with someone and they've reached a point where they feel stuck in the treatment, what recommendations or best practices would you advise to help understand the importance and life change found in treatment?
So there's a level of honesty, vulnerability, and humility that we have to show up with. And some of that humility includes, I don't know, I don't have the answers, or I'm not your person, or what we're doing is not your jam. And that's okay, right? It's absolutely okay, because at the end of the day, we want to support people to have a life that they want. But that means that if we're reflecting back on what we're doing, but we continue to do it anyways, and then calling the person non-compliant, as opposed to reflecting on what we're doing and saying, ooh, something's not resonating, right? Maybe it is connecting them with somebody else. Maybe it's the approach that's not working. Maybe it's that what I'm offering is not responsive to what you're saying you want or you need. And I have to get rid of the script and completely be followed by you. All of that is critical to people unlocking their lives.
And there's a lot of questions about 988 that have come up, and so I'm going to address some of those. And then there's some questions, Shireen, about the Pure Warm line, so I'm hoping you can provide a little bit more information. But for 988, it's a national number, and the way it's implemented is different in different states. We will send out the slides, and the coinciding brief that I mentioned also has a little bit more information, but we'll make sure you have kind of how to access 988 services, how to know where your local resource center is. But generally, 988, anyone can call it. It is, I saw a lot of questions about routing by area code. So it is by area code, so not geolocation. And there's been a lot of discussion nationally around geolocation, and there's concerns. A lot of people want to call and want to get connected to a counselor. They, as Sharina talked about, sometimes people have really bad experiences with the crisis system, where maybe they call and law enforcement shows up and they had no idea. And so there are lots of concerns and discussion right now around what's the best way to provide services to individuals that want to call and want this service, but maybe, want to make sure their confidentiality is maintained. So I wanted to address that because it came up multiple times in the chat. And I'll drop a link in that provides a little bit more about information about 988. And as I talked about a little bit in the slide, I know it was a very high level overview because we really wanted to get to this discussion. 988 and how it's implemented is very different in different states. Some it's integrated, some it's doing warm handoffs to, maybe this person would benefit from PeerLine and they can do a warm transfer to that. They can do warm transfers or even dispatch of mobile crisis. But it's very state specific because it depends on what continuum that state has and what level of integration. There are entities where 988 and 911 are working closely to transfer calls to ensure that it's a behavioral health led response. So some of those questions came up multiple times in the chat, and I just wanted to kind of address it. And Shireen, there were a couple questions about kind of the Peer Warm Line and level of support, and then also how your agency may be partnering with other agencies to bring individuals that might be reluctant to services.
Oh, it takes a village, baby, right? I actually was sitting with a gentleman a few weeks ago, and we were just kind of sitting and chatting, and he said, Shireen, this is you are the only people that have never been afraid of me, right? Like, you're the only people that have never been afraid of me. Why have you never been afraid of me? And it's heartbreaking and it's sad when those conversations come up. And keep in mind, the majority of the folks that we work with are the people that everyone else is afraid of. So yes, it takes a village. Of course it does. We have to have partnerships and allies throughout our community for a lot of different ways. And many of the people we work with have been rejected by services and systems, or have walked away. So we have to find very different out of the box ways of engaging and establishing relationships. The Peer and Warm Line was one example. During COVID, everything in our community shut down. The only crisis entry point we really ever built out was the emergency department, which shut down for non-COVID related non-COVID medical related emergencies. Our behavioral health services that are funded by Medicaid and state were not nimble enough to deal with the telephonic or the technologically based support because of services and the service definitions, and financially didn't support it. Well, we are a community of people that know what confinement feels like, whether it's prison confinement or hospital confinement. We know that. And we know the risk of overdose and suicide and domestic violence and abuse and neglect was significantly high. So within 24 hours of our state going on lockdown, we opened this 24/7 peer run phone line. It is staffed with 3 people at all given time that are all people who have shared experience. People call for a variety of reasons, everything from I'm considering suicide to I can't sleep. I'm hearing distressing voices. My service provider stopped serving me. They're trying to force me to take medications. Every possible imaginable life stressor that you can bring up in your mind are reasons people call the Warm Line. Within the first year, we had 35,000 callers. We did not expect that it was going to be so heavily utilized. I think part of the reason why it's utilized so much is the shared experience, the fact that people don't have to be concerned about confidentiality. It truly is a confidential line. We don't do geo-tracking or geolocation. We do not involve 911. And only one time have we ever called mobile crisis because it is really important for us to support people through distress. As a result of that, what we find is people feel safer to call a number where there's not fear of police showing up or fear of hospitalization. And the same thing with our respite. People feel more comfortable and safer to show up in an environment where they're not afraid that they're going to be hauled away with handcuffs and shackles or going to have their rights removed. Our Peer Run Respite is funded to be countywide. Anybody can call at any time, as frequently as they need to call. There are no limits as far as that goes.
I agree with you. The administration has always been hands-on and not afraid to be there when we need it through the thick of COVID. Even now, you guys are hands-on and able to come up on people and really be there for them in their low moments and in their high moments. So I do agree with you on that very much so.
This is a good segue, Stanley, because there's a question specifically for kind of you and Eric, and they were just interested in kind of your perspective on what advice you might give someone for individuals that may be struggling to engage in services in the present moment, and effective strategies for engagement and really bringing people into services.
I would say taking a chance, not being afraid to go at things you know, and at some things that you don't know, inquiring about things that you don't know. What can you get? What can be provided for you outside of what you want?
I,
Um, Go ahead, Eric.
no, I'm sorry. Go ahead.
No, go ahead. Go ahead. You got it.
I agree with you. Um, and also on my part, I understand as far as being scared of change, because a lot of people scared of change, scared to get help, thinking that people think that you are crazy or whatever. But I will also share my story far as part of the mental health part of my experience. Me, when I came home, because I had a bad experience in jail with them experimenting on me with the medication and all this, it was kind of hard for me to trust my caseworker. I was scared to take the medication because the medication they had me on, it messed me up real bad. And I had to take that chance. So my caseworker, and to this day, he's still my caseworker. When he went from one agency, I followed him because he talked to me as a human being. He didn't talk to me as I should do this, I should do that. He explained to me the benefits of it. Yeah, I do take medication and it works for me. Um, so basically, like Stan said, just try to trust the process. But when you're trying to change, it's kind of hard to, because you don't know what's going on, what's going to happen. You don't know if you're going to fail. You don't know if it's just going to work for you or not. And one thing that Stan said in the beginning is patient. I had to learn that the hard way because, like, when I came out of recovery, I was trying to do this and do that. I didn't have no patience. So that's the advice I would give.
That's right, Eric. That's correct. You're 100% correct. Just, they're not being afraid of change and of being afraid to adapt and adjust. Because at times, we're afraid. We don't want to change. We just want to go this way. The hiccup comes and we're like, well, why can't it just go this way? But you got to be ready to adapt and change and get the Band-Aid and just Band-Aid it up and wait for it to heal. Because sometimes it's going to be a long scar and you ain't going to be able to have it heal overnight. You're going to have to be patient and dress it up, with the Vaseline and the bandages.
Yes.
If I can, to add on to what you all are saying here, it's such a buzzword. We hear it all the time. Meet our clients where they're at. It's about meeting people where they're at. Yes. And it's about following their pace too, right? I have to let go of my agenda. Like, things are not going to happen on my timeline. You set the pace, you set the direction. I'm here to support you along the path.
I agree.
Exactly.
I think this is a really rich discussion and talking about, the sometimes overuse meeting people where they are, but what does that actually mean? What does it mean to meet people where they are? But I think the other theme that I'm kind of hearing, particularly if there's been frequent contact with a crisis system, is repairing trust. And how do you repair that trust? And how do you rebuild that relationship? And, Eric mentioned earlier, showing up. You keep showing up. You curse me out. I keep showing up. We talk through it. I think, communication when things are happening too, because, often we hear, I wasn't told. I have no idea what's happening. I don't know how I ended up here. And so I think honest and transparent communication and making sure you're taking efforts to repair relationships at every stage of this cycle. One thing that's come up a couple times in the chat too that I'd love the panelists' input on is talking about compassion fatigue and how do you combat compassion fatigue, excuse me, can't even get it out. Particularly in a system that, people feel like, I'm trying to help this person. I'm trying, we're going through the motions. We're in a cycle here. And how how can I, as a provider, help them, but also make sure, I'm taking care of myself so that I can meet their needs.
I feel like I'm dominating the conversation, so I want to create space for others to answer before I jump in.
Yes, that's a hard one right there, because it had to be some type of boundaries, but but you still help the person, because a lot of times we do take some of the stuff home with us. So I think you have to, when you do get off from work, so you won't take it home to your loved ones or whatever, just find your outlet. It might be listening to music. It might be going to the park, getting something to eat, ice cream or chess or whatever your hobbies is. But when we dealing with the consumer and we really working with this consumer and we really concerned with this consumer, it's hard a lot of times not to take it home, but you just have to find that outlet, not just go home and you just dealing straight with the family, or say you got to put this in or whatever, still doing work at home. When you leave work, you just have to leave it at home to the next day. I mean, leave work at work to the next day, but find that outlet. I mean, if that sounds right.
Yes, and from from the client perspective, you guys having compassion for us when you catch us in our vulnerable state, in our vulnerable moment when we're low and we're weak, and we might express more things that you guys ain't fully aware of, and you could come to more of an understanding instead of looking down on us, understanding where we're at in our vulnerable moment.
Yeah, and I would say as human beings, we're often wired to go to extremes, like we're all in or we're all out. The answer is yes or no. The truth of the matter is we are with people that live in the gray and survive in the gray, and we have to be able to hang in that gray space. That means that we have to show up with connection and empathy, and also look at that person and say, and this is how I do it. I don't know what would work for you all, but people ask, have you been doing this for so long? When I see people, I know what crisis and devastation and pain looks like and feels like. I know what it's like to be written off, but I also know what it's like to thrive. I know that I'm resilient and I know I'm a survivor. And when I look at people who are in the midst of all of that chaos and that crisis, I see the light, right? Darkness can feel really dark, but when the light hits, it's the brightest light that you've ever seen in your life. And we are being prepared through our darkest moments for that bright light. The truth is, the majority of us recover. And when I'm with somebody, I'm thinking, ooh, you have no idea what your future has in store for you, and how much learning and how much growth and how much muscle you are developing right now in your life. So I focus, again, that's about being in the wellness business, not in the illness business. I see pain and difficulties as a superpower, not as a negative thing. That superpower, being a mental patient, gave me a career. And it's a career that traverses international efforts. I get to work around the world because I started out as a mental patient. And so I want to make sure that when I'm in connection with people, their despair can actually be their biggest gift. And I want to view it that way.
My two go-to tips in this question are, I always come back to a metaphor of gardening. I think of myself as a gardener, right? I'm planting seeds, I'm watering them, I'm tending them, but I don't necessarily get to see the fruits of my labor. I might occasionally, but especially when you're working on a short-term scale with people, most likely you're not gonna get to enjoy the fruits of your labor, right? But just knowing that, like, I've set somebody else up to benefit from that is helpful. And for myself, I have found that having a hobby where I can see the fruits of my labor is really helpful. So I'm a knitter. That is one of my go-to things. I say I knit to unwind. Because we get so little concrete, tangible outcomes in our work, having something where I do that is really helpful to kind of have that balance.
Yes, we need that H2O at times, where the plants. And trust me, I love when someone in your position is watering me, because it helps us grow. It helps us grow and, level up, grow and become the fruit instead of just a plant, the wood and the stalk. You want to grow and blossom. It helps us blossom, I would say, into the direction we're trying to get to.
I have loved this discussion. I think there's been a lot of really great, fruitful topics. I know we're coming up on time. And to tie into this a little bit, we had a couple questions that I think our last question will be, for you, the panel, to discuss what they feel like an effective mobile crisis response looks like, and particularly kind of tangible strategies for people to use, maybe if they don't have lived experience, to, come into somebody maybe in the darkest hour of their life, and really what are strategies they can use to provide that effective response to somebody who might be in crisis.
I'm going to say one of the most profound things that I've ever learned, and it came from Marilyn Manson, believe it or not. So there was a film documentary about Columbine High School, and it was called Bowling for Columbine. And people are pontificating, researchers, educators, all these people, about mass shootings and high school students. And then they panned a picture of Marilyn Manson, right? And I'm thinking, because of my biases, really, what's Marilyn Manson going to teach us about high school shootings? And they asked Marilyn Manson this. They said, if you could go back and talk to the boys that did this, what would you say? And without even skipping a beat, he said, I wouldn't say anything. I'd listen. We lose it when we show up to either save people, fix people, be the interventionist, do something that we have been taught is what we do when people are experiencing distress, right? We've all been handed tools. And unfortunately, some of those tools actually are harmful tools to people experiencing emotional distress. And so when I show up in crisis situations, I am there to learn from you more than I am to teach you anything, which means that I have to suspend my biases, my instincts. I have to be able to control my own nervous system, right? Because, we're wired as human beings to either minimize distress, to make ourselves feel better, to blow it up, and then before you know it, everybody's in distress, or to try to fix it, right? But sitting with somebody in distress in a way where you are comfortable in being and listening and honoring and respecting, and not having to come in with all of these solutions, but being led by the person, is a skill. It's a skill that not everybody has, but it's a skill that can be developed. Mobile crisis teams, in order to do this job well, have to be good at really quickly establishing rapport, at sitting and being with people and listening and connecting, and then responding in various ways with as many tools as we possibly have in our toolbox to meet that person's needs at that moment. You know that saying, if all you have is a hammer, everything looks like a nail? We need to have as many tools as we possibly can have, because when a person needs a screwdriver, don't hand them a hammer.
Yeah, that's true. That's very true. Like planting. We got some gardening to do. You're gonna need different tools to plant. It's just not water and dirt. Then just pour it in, the plant just grows. You're gonna need some gardening going on to get some things going, to see everything blossom and grow, and yield the fruit.
And I just want to take a minute, because we are right at time, to really thank the panelists. The theme that came up when Shireen was speaking is really sitting with discomfort, sitting with not being the fixer, listening. I think there were a lot of really great themes and strategies that came up throughout this discussion. And I just wanted to take a minute to thank all of you for your time and your expertise. I think, it was a really robust perspective from various different geographic locations and parts of the continuum. And so I'm going to turn it back over to Jen.
Thank you all so much. I hate to wrap us up because we're in such a great discussion. I just want to elevate like the feedback from everybody on the webinar today. We had about 2,700 people and over 500 comments and questions. And there was just so much, people were resonating with what you were saying. They were feeling heard. They were feeling inspired. And I think there's no greater work that we can do than have other people feel heard and, inspired in their work. So to the audience, thank you. To our speakers, I just can't thank you enough for sharing your expertise today. We've got the links to the survey and the certificate. After this, we'll have the recording in about a week. I know I want to re-listen to it a few times because it was just so rich and wonderful. So again, thank you all, and to Jordan for doing a fabulous job moderating too. All right, until next time, we appreciate you and hope to see you again at MHRC. Thank you so much.